It is my deep sorrow to stand up here this morning together with three of my colleagues to pay tribute to our dear friends, Joep Lange and Jacqueline Van Tongeren. I first knew Joep in 1992, or about 23 years ago, when Joep was serving as WHO Global Programs on AIDS as a chief of the Clinical Research and Drug Development, where Professor David Cooper was the chairman of this steering committee for Joep's unit. I was a member of the steering committee. This is the reason that how all three of us got to know each other. Our friendship then, as well as the need of the HIV patient in Thailand, led Joep and David to help me setting up HIV-NAT in Thailand, which is the first HIV clinical trials center in Asia, the same way that they had in Amsterdam and Sydney. HIV-NAT was set up in July 1996, and January next year after, we then had the first Bangkok Symposium on HIV medicine. During the first 8 years of HIV-NAT operations, from 1996 to 2004, before Thailand launched the universal access to ARV, HIV-NAT has saved thousands of lives of HIV patients enrolled in the HIV-NAT trials. This, to me, is the most significant contribution of HIV-NAT, thanks to Joep and David. To me, Joep Lange is the HIV doctor activist that I admire most. He always addressed the issues of treatment equity between rich and the poor countries. He also championed in early antiretroviral treatment or treatment as prevention. As a person, Joep was a person who full with passion. Every time that he came to Thailand, he would always bring something along, maybe from Schiphol Airport, to give it to me. He paid attention to what people need, what people feel, and tried to do his best to help. This is a real friend. Now let me say a few words about Jacqueline Van Tongeren. I first met Jacqueline in January 1997 at the first Bangkok Symposium on HIV medicine, when she came along with Joep to the meeting as head of the clinical trials unit in Amsterdam. Jacqueline came to HIV-NAT maybe once or twice a year, either for HIV-NAT advisory board meeting, Bangkok Symposium, as well as HIV-NAT annual retreat. She was the one who arranged and managed the busy schedule of Joep, sometimes even answering the email herself on behalf of Joep. Jacqueline Van Tongeren will always be remembered by all of us here at HIV-NAT as a tall, thin, and beautiful lady with a smiling face all the time. You will never get upset or disappointed by talking to Jacqueline, but will always get a lot of helpful information and thoughts from her beyond medicine and science. Jacqueline was willing to help in everything if asked. At one time, she offered to use her expertise in organizing the interest workshop in Africa, which is also known as African CROI, to help HIV-NAT to bring up the greater access or greater success of the Bangkok Symposium. Least but not last, Jacqueline was a key person behind the success of all PhD candidates from HIV-NAT in Thailand for doctorate degree from the University of Amsterdam. She always helped in application, helping in planning the time for thesis examination, thesis printing, PhD ceremony in Amsterdam, as well as PhD congratulation party. So Joep and Jacqueline, we love you. And you will always be in our minds, in our heart. And we will follow your steps in fighting against HIV/AIDS. Thank you for your attention.
Thank you, Prapan. For almost 20 years, ever since viable treatments became available for HIV, Joep Lange was one of the first voices to advocate for antiretrovirals to be made available in low-income countries. Initially, the pharmaceutical industry was focused on treatments in countries which could afford the costs related to the enormous investment required to bring these therapies to market. We had watched the pandemic sweep through Africa, and we were determined to do everything we could to prevent the same devastation in Asia. Joep and I lobbied and cajoled and persuaded first one big pharma and then another to work with us in conducting research in our fledgling research centre, HIV-NAT, established in 1996 with our long-term colleague Prapan Panapak of the Thai Red Cross AIDS Research Centre. The resounding success in creating what is now a regional centre of excellence in HIV research will stand as one legacy to Joep's all-consuming passion to bring HIV treatment and research to low-income countries. Another legacy is his subsequent focus on increasing access to treatment in sub-Saharan Africa through the structures which he set up almost single-handedly. The Farm Access Foundation, which was among the first to initiate HIV treatment programs in Africa, and which in turn created the Health Insurance Fund, which provides subsidised health insurance in Nigeria, Tanzania and Kenya, and the Medical Credit Fund, which enables loans to private healthcare providers, Safe Care, which supports basic healthcare providers, and the Investment Fund for Healthcare in Africa, which invests in healthcare strengthening. Joep, the private man, was rarely seen without a book in his hand, in Dutch or in English, usually recently published literature, and often by his favourites, for example, the Portuguese Nobel laureate José Saramago. He was a great European and internationalist, and his ideas were always ahead of the curve. Social justice was his passion, along with literature and art. Joep was fearless, refused to take no for an answer, and loved any challenge that others had deemed impossible. He was a special person, a brave researcher, an invaluable collaborator, a great friend and colleague, and an international figure. His contribution to HIV research and treatment and his determination to ensure access to those treatments for people in Africa and Asia cannot be underestimated. I'm privileged to have been his colleague and friend for more than 2 decades, and I admire without limits his determination to bring improved healthcare to people with HIV in low and middle income countries. We are all the poorer for his passing. Thank you.
Thank you, David. After David Cooper, which is the co-director of HIV-NAT, the next person that will come to pay tribute is Professor Julio Montaña from University of British Columbia, who is also good friends of Joep Lange.
Thank you, Prapan. There is not much I can add to what Prapan and David have said regarding Joep. He was a giant in the field of HIV, and his contributions throughout his 3 decades of dedication to academic HIV research are well known by all of us. Beyond that, having spent a lot of time with Joep, what I missed and I will miss forever the most was his companionship, his friendship, his wit, his sense of humor, and his camaraderie. Traveling around the world in the academic circles tends to be taxing and at times a little bit of a challenge. But it was always a pleasure to come to a meeting when Joep would be there, because it would be the added piece of fun and enjoyment that is often so difficult to find out in these endeavors. We had a great time together. We enjoy a good time, we enjoy a good meal, we enjoy a good glass of wine. And I remember for the rest of my life, the one time that we went fishing in Seychelles, which is a place very close to my home in Vancouver. And neither you or myself, we knew how to fish. This was in 1996. I just had bought a very small dinghy, and I was trying to teach him how to fish, which I didn't know, of course. And we were casting around the shores, and Joep all of a sudden got so excited because he got caught a little fish about this size. That, of course, by the time that he brought it into the boat, the fish was no good. So we threw the fish over the board, and we carry on fishing. And all of a sudden, we hear this gigantic noise behind us. And it was an eagle that had come down to catch Joep's fish. It was the most impressive thing we ever seen. And after that, ever since, whenever I had visitors, I catch a small fish and I feed it to the eagles. And that's a sort of way of remembering Joep and his passion. This little trick that I learned with him, that is actually the most valuable memory that I can share with you today. We'll miss Joep and Jacqueline, and we'll miss you dearly. Thank you.
Thank you, Will. The next speaker will be Professor Peter Rice, the close colleague of Joep Lange. He's a professor of medicine at the University of Amsterdam. So, Peter, please.
Good morning. It feels very strange to stand here and realize that Joep and Jacqueline are not sitting in the first row working on their laptops, because that's something that I've, of course, witnessed many times. And I decided not to prepare my comments and just speak from the heart, because both of them were very close friends and colleagues. I knew Joep for over 35 years. We went to medical school together, and just by chance professionally connected again in 1981, 1982, when we happened to be taking care of the first 2 patients with HIV in Amsterdam, who turned out to have infected one another. And that journey since then never ended. So we've worked together in various capacities and have shared numerous anecdotes and memories just of the type, not with the eagle though, I didn't know that one actually, that Julio just mentioned. But there have been many, many examples where we met, and being in Bangkok, I also realized that in fact it was Joep who introduced me to Thailand and who introduced me to Professor Prapan and many of the people sitting in this room, and I'm very, very grateful for that, because it has led to many friendships and interactions throughout the years. And I think being here in Thailand, it's very important to say that I think Thailand had a very soft spot in the hearts of both Joep and Jacqueline. And they would never miss an occasion to go to Thailand. I mean, Joep's schedule, I think Prapan already said it, Jacqueline was the one managing his schedule, or at least I should say trying to manage his schedule, because it was unmanageable. But they would never miss the opportunity to come to Thailand, and they would set aside whatever needed to be set aside, and they always made sure that they came. And I think one of the highlights, and it's something that Joep and I actually talked about earlier this year, when we were lobbying to bring the International AIDS Conference to Amsterdam in the future, was the fact that he was chair of the International AIDS Conference here in Bangkok. I mean, that was, in his mind, really one of the highlights of his career, and I think we should also realize that Jacqueline played a major role in that conference. And I think it was the conference where the so-called leadership program started, and I still have very, very clear memories of Jacqueline helping Nelson Mandela onto the podium at the time of the Bangkok conference. And it's one of those visual memories that came back after this July's tragedy. So I think I'll leave it here. I think we missed them all. I missed them every day. I made a point of hanging a picture of them in my office, and many people comment on how I could do that. And I said, you know, it helps, because whenever I'm at work and I think, oh God, how do I get myself out of this? I just look at the picture and say, could you please help, guys, from up there? And it's a way for consolation. And I think all of us in Amsterdam, and that also holds for the collaboration that we have with the people here in Bangkok, try to continue their legacy as much as we can. But we do miss them. Thank you very much.
Thank you, Peter. Before coming to the end, I would like to ask everyone, please stand up in silence to pay tribute to Joep Lange and Jacqueline. Thank you all.
I am very honoured to be asked to introduce this inaugural Joep Lange and Jacqueline Van Tongeren Memorial Lecture. There are many ways to honour someone we have lost. Today we remember two people with love and admiration for themselves as much as for their contributions. And with the start of this annual memorial lecture, we are linking their names with scholarship, with knowledge, achievement, and hopes for the future, all very relevant attributes to offer to the memories of Joep and Jacqueline. It is also deeply appropriate that our speaker for this inaugural lecture of commemoration is Julio Montana, a scientist researcher who has consistently challenged the prevailing orthodoxy with his creative approach to ART and its applications. A past president of the International AIDS Society, Julio has been at the forefront of every major development in the history of HIV/AIDS, particularly in combination therapy. He is now front and centre in advocacy for treatment as prevention, both in Canada and internationally. I've known and worked with Julio ever since he, Stefano Vella and I, together with Joep, worked on INCUS, which was one of the first studies to demonstrate that triple combination therapy rendered the virus undetectable by preventing the emergence of resistance. And that was truly the turning point in our field. Please welcome our speaker for the inaugural Joep Lange and Jacqueline Van Tongeren Memorial Lecture, Dr. Julio Montana.
Sorry, change your plans. Thank you, David, and thank you for your kind remarks. Thank you, Papan, for the invitation. It's a pleasure to be back in Bangkok. Sad to be here in the occasion of remembering Joep. As you heard, Joep was not just a colleague, a leader, and a pioneer in the field of HIV, but above all, he was a great friend. It gives me great honor to present this memorial lecture to Joep. It may not be apparent to you all how fundamental Joep's contributions were to the development of antiretroviral therapy. David alluded to some of that in his introductory remarks. I can tell you that behind the scenes, Joep was a great promoter of treatment and prevention, as I will discuss with you here today, sometimes in ways that I'm not allowed to publicly disclose. Anyways, I thought I'll share with you a couple of brief pictures of Joep early on and Jacqueline, who we miss dearly, before I move on to my presentation. I'd like to start this discussion with a historical slide. This is a slide that clearly depicts what many of us faced in the early days of the epidemic. That red line there seemed not to be having a stop. We in the 90s did not really have a plan how to address the rising number of AIDS cases and deaths that were accumulating in North America and elsewhere in the world. Interestingly enough, it was around that time that David, Stefano, Bella, Joep Lange, myself, Mark Weinberg, and a few others, Maureen Myers, more prominently, had an opportunity to come together and start the INCAS trial. INCAS is derived from the Italy, Netherlands, Canada, Australia, and the States involvement in that trial. And in that trial, we tested in a rather exploratory way the role of triple therapy using ACT-DI and nevirapine. The trial matured in 1995, around the same time that the Merck 035 trial matured. And the following year, we saw, as a result, the emergence of triple therapy, which was deemed as highly active antiretroviral therapy, or HART, which led to a revolutionary change in the standard of care for HIV medicine, and with it, the remarkable decrease in death rates and extension of survival that we have seen over the last 2 decades. I don't believe that there has been ever such a revolutionary development in medicine, whereby 2 clinical trials, largely exploratory phase 2 studies, were able to shape public policy in a way that within 6 months we had turned around what it was a devastating pandemic. What we didn't realize at the time, and it was not readily apparent quite yet, was that in implementing triple therapy broadly, we not only were having an impact on morbidity and mortality, as I showed in the previous slide, but also on HIV transmission. And in the province of British Columbia, what we saw was, as you see in the red line here, a remarkable decrease in new infections at a time in which syphilis was actually on the rise. And that gave us the impetus for us to evaluate the role of treatment in terms of preventing morbidity, mortality, and secondarily transmission. And in doing so, we generated the hypothesis that treatment could act as an effective means of curbing the impact of the epidemic, so that in 2006, we felt that there was enough evidence for us to make the proposal that expanding antiretroviral therapy to all people infected with HIV would actually lead to an undetectable viral load for their own benefit, and thereby preventing morbidity and mortality, but secondarily, through the sterilization of biological fluids, decreasing HIV transmission. In a remarkable turn of events, the province of British Columbia, very early on, decided to adopt this thinking even before the evidence was really in. The Premier, Gordon Campbell, was very progressive in his thinking, and he actually told me point blank, with my money and your strategy, we're going to conquer HIV. And so we did. Very early on in the 2000s, we decided to re-expand our treatment program. So what I'm going to show you next is the 3 phases of expansion of antiretroviral therapy. The first phase, following 1996, a rapid expansion based on the emerging data from the INCAS and Merck trial. Then a plateau that occurred between the years 2000 and 2003 when there was a great deal of anxiety regarding the role of antiretroviral therapy, the emergence of resistance, the sustainability of the treatments, the difficulties associated with the first generation antiretroviral therapy, and then what happened following the entry of tenofovir-based treatment, safer, simpler, more effective treatments, and the awareness that treatment could actually contribute to decreasing HIV transmission, which allow us to expand the treatment as you can see here. And so what you see here is the actual history of the HIV epidemic in British Columbia. Before antiretroviral therapy was effective, in the pre-HAART era, you see the early decrease in new AIDS cases following introduction of triple therapy. You see a new plateau arrived at as a result of that, but you also see that it wasn't until the early 2000s or mid-2000s that we managed to decrease AIDS new diagnosis once treatment as prevention was introduced in the province. So from a population perspective, you see here a morbidity benefit associated with the liberalization of the access to testing and treatment. From a mortality perspective, you see the same trend, a remarkable decrease in mortality early on with introduction of treatment, triple therapy treatment that is, a plateau phase here until the mid-2000s, and then with introduction of treatment as prevention, you see virtual control of AIDS-related mortality in the province of British Columbia, as shown in this slide. So much so that our AIDS ward has now been closed and repurposed for the use of people living with HIV who are aging gracefully, I hope, with HIV. And then separately, I show you here HIV new diagnosis declining significantly early on with the advent of highly active antiretroviral therapy, and then again with the expansion of the treatment into a treatment as prevention strategy. When we started this program, there were some that were critical about us making treatment available, particularly to injection drug users, which is something that should be of importance to you here in the Bangkok area. We did so in the context of expansion of harm reduction strategies, including supervised injection, and it's been done as it has been done in other places, including Australia and Europe. And that allowed us to create low threshold environments that were welcoming to injection drug users so that they can fruitfully engage on antiretroviral therapy. The results have been rather remarkable. We have seen a marked decrease in HIV new infections, not only morbidity and mortality, but also new infections, particularly among injection drug users, to the point that today we have seen a nearly 95% decrease in HIV new infections among injection drug users through the combined effect of treatment as prevention and harm reduction strategies. Now, British Columbia has been uniquely aggressive in the pursuit of treatment as prevention in Canada. The health system in Canada is a national health system, but the treatment and the management strategies are set provincially, so that each province has a different set of guidelines and approaches to whatever healthcare issues you're looking at. And so British Columbia is the only place where treatment as prevention has been implemented, and it has not been the case across the country despite of our efforts and our lobbying. We have a fairly, I would say, conservative government federally that has not been interested in engaging in HIV-related issues because they confuse public health with morality issues that I will not discuss any further. What you see here is that as a result of the apathy of the federal government and provincial governments elsewhere, British Columbia is the only jurisdiction that has actually seen a declining HIV new diagnosis. As you see here in the red line, British Columbia had the worst HIV epidemic in the country on a population-adjusted basis back in the 90s. Today, it continues to see a significant improvement in HIV rates, which is in contrast with what we see in other provinces, particularly Saskatchewan and Manitoba, where there has been a sharp rise in the number of HIV cases. Note that no other jurisdiction has seen decreases in HIV of the magnitude that we have seen in British Columbia, and this is a matter that we are actively pursuing with the rest of the government. This has implications for health, but it also has implications from a cost perspective. The savings from averted HIV cases has been illustrated by this preliminary work that has been done by Bob Hogg in our group. And what you see here is the significant savings generated by our program in British Columbia, in contrast to the mortgage that has been generated by the lack of action, for example, in Saskatchewan, illustrating that this is not just about saving lives, but also about saving money. The critical issue in order to optimize the role of antiretroviral therapy in the context of treatment and prevention is the monitoring of the cascade of care. This is something that we need to get a handle of if we are going to succeed in controlling HIV in the years and decades to come. We have used the cascade of care as a means to monitor the progress of our program, and what we do is on a longitudinal basis, we monitor the number of people diagnosed, linked, retained on care, on antiretroviral therapy, adherent to antiretroviral therapy, and virologically suppressed. And while some of these measurements can be arbitrary, it's important that by using consistent definitions, we look at them on a longitudinal basis to see that we are closing the gaps where the gaps exist so that we can derive optimal benefit from our strategy. It should be noted, though, that there are significant heterogeneities when it comes to the cascade of care, and so it is not really adequate to look at the cascade of care as a whole. We need to look at it stratified by different subsets of individuals and populations. To illustrate the point, you have here IDUs and non-IDUs, and despite the fact that we have seen benefits among the IDU population in our province, you see that the cascade of care is falling behind in IDUs compared to non-IDUs. We have done similar analysis by gender, by other risk factors, by geographical jurisdiction, and I think the important thing to notice is that the cascade of care can be used to identify at the very granular level where the problems exist or remain and how that can be addressed. There has been a concern also that resistance would emerge as a challenge in the context of rolling out antiretroviral therapy to a larger group of people and a more vulnerable group of people. I'm happy to tell you that this is not necessarily the case. Yes, it can happen, but it's not necessarily the case. In our experience, resistance actually has decreased, as you can see here. This light blue on the top is multiple drug resistance. That has almost faded completely over the years that we have been expanding treatment. The reason for this is twofold. First, the program has become smarter and more focused in its ability to support people who have other challenges, whether it's mental health, addictions, homelessness, etc. In addition to that, we have better, simpler, more effective treatments and second-generation treatments that allow us to treat people with multiple drug resistance effectively so that we have virtually erased that as a significant clinical program. We should remain vigilant because this can reemerge if we don't pay attention to it. But the good news is that multiple drug resistant strains is not necessarily a consequence of expanding treatment. We have looked at this in particular among injection drug users. This is a meta-analysis that Dan Werb did within our group, and I'm happy to tell you that having reviewed all of these publications, really the odds ratio for emergence of resistance in this population is basically 1. There is no significant risk among IDUs, particularly with the newer modern antiretroviral therapy regimens. And there are additional strategies that we're exploring, including the use of financial incentives. I'm not going to go into the details of these, but suffice to say that the preliminary results from our incentive randomized control trials supported by NIDA at the NIH shows that our ability to engage hard-to-reach populations into effective strategies for testing, treatment, and long-term sustainability of antiretroviral therapy seems to be extremely promising with these kind of approaches. The value of treatment of prevention is no longer controversial. The HPTN-052 has definitively demonstrated that by treating an individual within a serodiscordant couple, you can decrease the likelihood of transmission by over 95%, and in fact, secondary analysis suggests that this could be as high as 100%. As a result, the United Nations AIDS program has been enthusiastically supporting inclusion of treatment of prevention as a leading component of our AIDS control strategies. And this has now been endorsed by a number of political leaders throughout the world, including President Obama in December 2011, who began to talk about the beginning of the end of AIDS. Whether or not that's a fact remains to be seen. President Clinton has been unwavering in his support of this strategy, starting already in 2006, when he became really a champion of the treatment of prevention strategy. More recently, UNAIDS has proposed a new post-2015 Millennium Development Goal, the so-called 90-90-90 target, which calls for us to, by 2020, identify 90% of all people infected with HIV globally, so that at least 90% of them can have access to high quality and sustainable antiretroviral therapy, so that at least 90% of them can achieve an undetectable viral load, so that in doing so, we can dramatically change the course of the epidemic. If we meet the 90-90-90 by 2020, we would have 73% of all people living with HIV virologically suppressed, which means a threefold increase in the number of people who are virologically suppressed today. The ultimate goal of this exercise would be to maximize the effectiveness of existing tools by 2020 to virtually eliminate progression to AIDS, premature death, and HIV transmission, and thereby to transform the HIV and AIDS pandemic into a low-level sporadic endemic by 2030. Notice that when we talk about virtually eliminating HIV and AIDS, we're talking about reducing the burden of disease, morbidity, mortality, and transmission by approximately 90% from 2010 levels, not disease eradication. The 90-90-90 represents probably the boldest and most ambitious target for HIV control globally yet ever put forward. I'm delighted to say that this has now been endorsed by the Secretary General Ban Ki-moon, and I thought I'd close with this slide, which is kind of an interesting paradox. This was taken, I actually took this slide during the Melbourne conference when Michel Siribe presented the strategy, or was about to present the strategy of the 90-90-90 to the conference for the first time. Interestingly, he did so with an introductory slide quoting Joep Lange when he famously said, as he used to say repeatedly, if we can bring a bottle of Coke to every corner of Africa, we should be able to also deliver antiretroviral therapy. That was his mantra, that was his goal, and I believe that the 90-90-90 truly crystallizes that image. Interestingly, before even Michel presented the 90-90-90 strategy, there was a community manifestation at the conference by which the community was asking leaders to commit to undetectable viral load for all by 2020. And in a kind of interesting way, this brings together Joep's thinking, UNH thinking, and ultimately the community thinking. This should be the goal for all of us in honor of Joep's memory, so that once and for all we can end this devastating epidemic. Thank you very much.
Thanks, Julio. I think we've got some time to take a few questions since it's such an important lecture. So the actual quote is interesting. It's, "Joep never said a bottle of Coke, it was a cold bottle of Coke." And,
that's right.
And I think that's really important because it's supply chain dynamics, isn't it? That you can actually keep the cold chain going and in an isolated area. It was a very innovative thing to say that it was a cold bottle of Coke. So let me start by asking you, what you've achieved in Vancouver, and similarly what the group's achieved in San Francisco of reducing HIV incidence, and perhaps some tantalising trends in KwaZulu-Natal on ecological studies. So let me just give you the example of my own city, Sydney, in a country which thankfully has, universal health care, no barriers to antiretroviral therapy, no discrimination, positive attitudes to gay men and women in Australia, and positive attitudes to injectors amongst the healthcare community. Why do we still have an increasing HIV incidence? And similarly for other wealthy cities around the world, what lessons can we learn from Vancouver and San Francisco that might help us with our epidemics?
So the point that David is making is very important. The success that we have seen overall in British Columbia it has been uneven in different groups affected by HIV. We've seen the virtual elimination of mother-to-child transmission, and we have seen the virtual elimination of HIV in the IDU community. The decrease on HIV infections among MSM has been slow. We're comforted to see a slight decrease, but as you've probably seen in the most recent Lancet article that Tony Kirby published about a few weeks ago, the trends among MSM are disturbing. We have not had the success that we would hope for in the MSM community. So it begs the question, why are we having this differential impact? And I believe quite strongly that this is a combination of a couple of factors, among others, but a couple of primary factors. There was a time where there was a concern that treatment and prevention may not be as effective in MSM that it would be in other settings. Fortunately, the results of the partner study presented in preliminary fashion at the CROI meeting last year, and hopefully to be updated soon, suggests that the individual level effectiveness of treatment and prevention in MSM is of the same order of magnitude that it is in heterosexual couples. So that addresses the biological concern. What we have, though, is that among MSM, we have treatment and prevention operating virtually in isolation. Abstinence, condoms, and a limited number of partnerships are not really operational in our MSM epidemic in British Columbia. And so we are left with treatment and prevention. The networks are very rich, therefore, and so in order to protect a single MSM, you need to reach a very high level of protection in that network. And so what I'm suggesting is that treatment and prevention operating on itself, in order to be effective, to be highly effective in the MSM community in British Columbia, will need to reach a very high level of coverage. In the IDU community, this is actually simpler, more effective, easier to achieve, because we have harm reduction strategies that virtually address that network, diminish the size of that network. And so I think it's a matter of coverage. The biology is strong. It shows that the strategy works. What we need is to get very high level of coverage so that we can protect MSM from HIV at the earliest possible time.
Thanks, Julio. Anyone else like to ask Julio a question? Or? Yeah, one here. Yeah, identify yourself, please.
Hi, my name is Suresh Randarajan. I'm from FHI 360 and been working in Vietnam the last 5 years. Julio, I've attended the conferences in Vancouver on treatment and prevention the last few years and have pushed for treatment and prevention in Vietnam. One of the issues, and it's exactly to the point that you're talking about, is about as we start to think about expanding, you're talking about high levels of coverage. But in Vietnam, we're considering broadening treatment eligibility to high-risk key populations now, but we don't have the financing. And I wonder, and I'm trying to ask, is for concentrated epidemics, particularly the MSM, which is exploding in Ho Chi Minh City right now, similar to Bangkok, how can you come up with a strategy that doesn't involve having this massive coverage of the MSM population, which could be a large population? I mean, there's estimates 100,000 to 200,000 MSM in Ho Chi Minh City. How can you target these social groups or these networks so that you could maybe get more return for your investment by breaking the cycle in these high-risk social groups? What's your experience in Vancouver, and is there any viable risk assessment strategy for doing treatment as prevention?
This is a very challenging issue. I believe that our goal should be to expand antiretroviral therapy to all people in need, which by definition today means everybody infected with HIV. And I'm not really willing to compromise from that strategy because issues of fairness and equity would become very problematic if we step down from that position. Having said that, we have learned through our work that actually you can be very smart on how you roll out these programs, because at the end of the day, you can't roll these programs from 0 to 100% coverage overnight. And so there is a real virtue of using hot spotting in order to do that. And so how do you do that? Well, you really need to go after the most concentrated areas where HIV is problematic. We did this without knowing what we were doing when we started the program. And I tell you a bit of a little story here. When I went to meet my premier and I asked for additional funding to expand testing and treatment access, facilitating access throughout the province, he endorsed that, no questions asked, except that by the time that the bureaucracy got to sign the documents, our fiscal situation, because of fiscal crisis, which is something that we all live with, was problematic. So they came back to me and they said, sorry, the premier agreed to that back then, the finances are what they are, how do we set a priority? So I went back to the premier, and in fact, he made the decision for me. He said, we're going to go to the 2 areas of the province where we had the highest mortality. So it wasn't morbidity or it wasn't HIV transmission that drove his decision making. As a politician, he felt that he could not justify doing something for an area X when there was an area Y that had a significant increase or added surplus mortality, if you want. And so that's what we did. We said, we're going to launch the program provincially, but we're going to add financial resources to the 2 epicenters of AIDS mortality. As it turns out, we were doing hot spotting without knowing what we were doing. And it worked well for us. Since then, the epidemic has now decreased, as you can see. So what we're currently doing is we're using real-time phylogenetic mapping to identify foci of reemergence of transmission. And so we use the phylogenetic mapping, which we do on a real-time basis for every virus that is detected de novo in the province to tell us what jurisdiction we need to go to address an emerging epidemic. So anywhere where we had 2 viruses emerging within the same month that are linked, for us represents an emerging epidemic, and so we go after it. So at the macro level, you can do hotspotting by using morbidity and mortality data. At the micro level, you can use phylogenetic data. There is a wide spectrum of strategies that you can use to actually be more effective how you target your investment.
Okay, Julio, thank you very much.
Thank you.
Please join with me in thanking Julio. I think he's set a very, very high standard for the first Joep Lange and Jacqueline Van Tongeren Memorial Lecture, and obviously we'll continue that in future Bangkok symposia. So it's a pleasure to introduce the next speaker, Frits van Klinsven, who's currently the Assistant Director for HIV Prevention at HIV-NAT here in Bangkok. Frits has had a long and distinguished career in HIV prevention, initially in the Netherlands and more recently with various agencies here in Thailand, and has done a huge amount to alert us all of the very concerning emerging epidemics of HIV infection amongst MSM here in Bangkok and in many other Asian cities, as the last questioner pointed out to in Ho Chi Minh. Frits is going to talk about prevalence and incidence in Asia and talk about evidence-based strategies to curb the epidemic. Frits, very welcome to you.
Thank you very much, David. Good morning, everybody. Well, I actually looked to talk about new strategies, possibly curbing the epidemic, but I couldn't find very many since the last time I talked about it, which I think is about a year ago. So I think we have to look at what we already know and what I assume that you already know, so I don't have to tell you that whole story again. So what I'm going to talk about is evolving epidemics and evolving responses, and I'm going to take mostly Thailand as an example, and from Thailand I will take the MSM population, because that's the group that I'm the most familiar with as my subject, as the subject of my talk. If we talk about epidemics, that is something that happens in reality. Now, as well as prevention, next to an epidemic we have that occurs on a certain level, occurs in a certain way. There is a universe of prevention that we actually don't know, nor do we know the epidemic very often. So we tap out of these two dimensions. We tap our knowledge, which is epidemiology and science. So that's what we have in our minds. And what happens next? We make yet another translation to put it in practice, in reality, and then we deal with concepts as stress and fit and external validity, internal validity. So you have one side, you have the epidemic, that's the reality. Then is another step is what we know about it, and then what we know about it actually, when we put it to practice, may actually not work very well. So there's lots of trouble there, and actually inconsistencies and things that are not known. So there's, of course, there's feedback. So it's a very beautiful figure, this. And then so you see the reality, knowledge, and practice, and then, stress and fit problems between reality, knowledge, and implementation. We have that all the time. Now I'm going to take you, I'm going to take you back to the end of the last, the century before that, the end of the 19th century, when, so you probably know this, some of you may know this strip, Sisken and Wiske, and there is a professor there, and he has a time machine, so you step in there, and he switches then the button, and then, so basically what it is, that's the machine at the left side, and see, it gets already a lot more interesting, I think. think this is the, yeah, that. So that is the machine. You go in there, and then he switches the handle, and then whoop, you go to the past, and you go in here, and then you come out at the other side, and then you 100 years or 120 years back. So you can look at how things were then at that time. That machine was actually called the teletime machine, he called it, and I changed the name in the epidemic time machine. So we're going to look at the conditions before the epidemic actually took off. So we go for a journey in northern Thailand towards the end of the 19th century, around 1890 to 1900 in that time. And you can see these are I think the Thai people here will know very well where they come from, Wat Pumin in Wat Nan. And they are actually quite revealing, you know, for what was the everyday village life in that period. So this is one of them. These are kind of what we think, or what people think is the regular scenes out of the village life that the painters put on the walls of the just restored temple in Nan. And you can see there's things happening, people gathering, certain characters that are a little bit too close. You don't have to be so close. And then there are, well, the people doing all kinds of things. So here's another one. As you can see here, these are the military. They're coming into the city wall. They continue. There's a few women folks hanging out. I don't know why that would be. And then here there's also a whole group of women that's hanging around the military. And so I do not know actually why this is. It's just how I look at it. Maybe the people who painted it had a totally different meaning. But it's a very lively thing happening there. And then here we take a better look at the group that was standing next to the military. You can see here there's courting is going on, and at that period of time, you know, more than 100 years ago, you see here. Let's see what they're doing. They're schmoozing, and actually it looks like there's also a woman that is smoking, which is a little bit unbecoming, you know, for Thai culture, at least culture in the past century. Women who smoke, that's really a no-no, because it doesn't look very good. And then if you really, yeah, indeed, she's blowing a big puff out, and so she is, you know, lighting a cigarette for this gentleman, and also that goes in a very close range of contact. Here's also another one, which there is. Well, it's clear, I think, what they are doing. Don't have to tell you that. And then also, apparently, there was drinking and sitting around. Pretty much, actually, what people in North Thailand do. So it's a very liberal kind of society and easygoing, and everybody has a place under the sun. And it's I think it would have been a nice environment for myself also. I came across this mural on a report that was printed in 1993 by the Thai Red Cross Society. It was a report written by Tabisak Nopkasorn, and there is a commentary in there from a Thai professor. I forgot her name, and she proposes, and I thought it was very realistic. Actually, she proposes as a remedy against the emerging HIV epidemic that the law on forbidding making alcohol in the house, because Thai people used to make rice wine in the back of the house, and they would drink from it, and they would stay at home, get drunk, and of course it would be noisy and all kinds of trouble. But she argues, now they don't do it at home anymore, but they go out, and they go to the women. And so you have to repeal that law, and you have to make sure that they stay at home, that they drink at home, and that they don't go to drink, you know, where they can buy sexual services, etc. Because then you have a problem. So it'd be better for them to make alcohol at home and don't go out and just drink at home. And I thought it was almost a Dutch solution, I think, for a social problem. Here's a few more, and I'm just showing them to you one by one. And I think you probably can figure out for yourself what this is about. There is always, let's say, there's always one particular character that stands out, a minority character. Yeah? Oh, whoops, yeah, and another one, yeah. So these actually are not from Pumin, they're from Prasing in Chiang Mai, these murals. And you can see there is this gentleman who is not very masculine, and also this person. And then again there is one here, and there's one there, and this is a transgender couple. And when you look at the mural a little bit bigger, you can actually see that somebody's very stressed out and probably jealous and kind of under duress because she has lost her man. So that's a problem. But you see that there is this well, these would be, I think, what we now call transgender, and we have all these operations and procedures and silicones and this and that, so they don't look like that these days anymore, but I think in the old days they looked pretty much like that. And it's also proportionate. I think it's within the 5% range, I would say, that these characters are in the murals. So it's not overdone, it's not like in your face, it's very measured, I think, a dosage that I think is tolerable in that setting. But where do I go from here? Now, we go to 100 years later now, in the province of Payao in 1990. And we're looking at risk factors for prevalent HIV infection in 21-year-old military recruits in Payao. And Jan Nopkerson, I think, led this investigation. The book was published by Thai Red Cross. I think Dr. Papan still remembers it. It was also part of it. And you can see here, because they thought this is a disease that comes from homosexuals, from gay-related immunodeficient men. And so they were looking for that trace. So they asked a lot of questions about same sex and everything. But then when they started to analyze the data, they found actually a big zero. There you go. So there was nobody of the young men they had in their study, and this was one particular base in Payao. So it was a census of that base. Of all the men who reported to have had anal sex, none of them had HIV infection. And the ones that didn't have anal sex, 21 had HIV infection. So now you calculate that in an odds ratio, and you see not having anal sex had almost an odds ratio of close to 40 as your risk for HIV infection. So I think what you would do, if you don't think about it very long, you would go out and have anal sex, right? That's what I would do. And I think some people actually have done that. But so I think they probably, I don't know, maybe Dr. Papan can tell me what happened in those days. I would like to know the discussions that they had, when they found these data, because they were looking for something and they found something opposite and they didn't know how to explain it. But in the meantime, there was an outburst of HIV infection in female sex workers, and the virus was spreading throughout the country at a very rapid pace. See, 40. Now, the second investigation in the neighborhood, in Pisanolog, a little bit lower in the country, they also asked about sexual behavior, and they found that 63 or 64% of those who had sex with another male, so it's not from everybody, 63.5% had only insertive anal sex. And there was a smaller, well, of course, a smaller because it together is 100%, and 37% actually had reported receptive anal sex. So there were fewer receptive men than insertive men. So I think the insertive man would have then to share all the receptive men in order to make everybody happy. I think that's basically the idea. Now, there is a discordance between the version of your PowerPoint and mine, and I have the newest one because there it says value there. It shouldn't be there. That should be 10%. It is because I have PowerPoint 2014, which I buy from Microsoft in the United States at a good price, and so that should not be value because it doesn't recognize. I sincerely apologize for that. Now, among the insertive men, 10% had HIV infection in Pisanologue, but none of the receptive men had HIV infection. So I think that made things worse, because how can the insertive men be infected if the receptive men don't have HIV? So, and since the receptive men were not infected, so the insertive partners couldn't be infected, but still they were infected. And so, yeah, it was, I think, I don't know how they solved it, but it looks to me, it looks like a big problem. So why did I tell you this story? The conclusions from the epidemic time machine. There is several very important and fundamental and for an epidemiologist, very, very important conclusions can be drawn from this small piece of work. And I think it's a great story, and it's fantastic that they have collected all those data and following the leads from the West, etc., etc. So what was happening and what were the conclusions today? Yeah? So I'm not saying that they would have had the same conclusions at that time. The outburst of heterosexually transmitted HIV infection in northern Thailand, which eventually would claim 800,000 lives, that's today, yeah, was not matched or preceded by an HIV epidemic in men who have sex with men, which was the hypothesis. So they had to reject that hypothesis. Apparently they were separate epidemics. But as you may recall, there was somebody who wrote a paper about waves, like there was one wave, and MSM were kind of the harbingers, like stirring up the wave, and then a bigger wave, and another one. But if you look at these data, that concept actually, that person may not have known this information at the time, but right now it's very unlikely that there were such waves. HIV infection did not seem to be acquired through anal receptive intercourse. That's what you have to read from the data. Why that is another question, of course. You can explain that. And then the insertive partners of receptive men should therefore be HIV uninfected. That's an inference, because if they didn't have it, then their partners couldn't have it either. Insertive men were unlikely receptive and vice versa. So there was wall separation already going on between these two groups. Insertive and receptive men in this cohort were also segregated because the insertive men had HIV, but the receptive men didn't have, so they were separated. So they were segregating or assortative mixing as it hears today. And then the insertive men must have acquired their HIV infection elsewhere, yes, and must have had their insertive sex elsewhere as well, because their receptive men didn't have it. Insertive men and MSM were not the same men. So that was, I think, the conclusion, that these insertive men and the MSM population, where the receptive men were in, they were separate. And they were culturally, socially, sexually, and behaviorally different. Now, you can maybe over the coffee talk about what the solution is. I will not tell you, but I will go on. We go back to today with the time machine again. Yes. So now it's 2010, and this is from Dr. Ram from Pamankut Klau, College of Medicine. And he has, in his military recruits, and it's all the military recruits in Thailand, there's every year there is about 60,000 in 2 rounds. This is from 1 round, I believe. heterosexuals, bisexual, and homosexuals. Classifies them as such. There, of course, the most of them are heterosexual. There are some bisexuals, and then less so there who are classified as homosexual. I think he used a combined measure of identity and behavior to classify them. Now look at this. The homosexual men, the bisexual and the homosexual men, who are let's say, the anal receptive guys, now they have a lot of HIV infection. And proportionally, they have a lot more than the heterosexuals. So now if we calculate the odds ratio again, and now it's over three categories, so it's a bit more complicated, so I had the computer do it. So it's I think I have that in a circle. Oh yeah, there's 32 infections out of 339, and the odds ratio is 35. So whereas, in 1990, the odds ratio was close to 40, for risk if you didn't have anal sex. And now 20 years later, the odds ratio is about the same, but it's reversed. Now it's because of you had anal sex. Now that shows you actually why I'm showing you this is the enormous transition the country has gone through since the beginning of the epidemic. And I don't think that is an easy thing, and I think we actually underestimate how difficult it is once you have a whole government, private, public sector, NGOs, etc. You have focused on one thing, and then little by little over time, it has to change, like 180 degrees and look in a totally different direction that people are not familiar with, etc. All kinds of trouble. Now, so that's not an easy thing. I just want to make clear that if people criticize Thailand for maybe being too slow or this is not perfect, I think we have to understand, what it takes to because they already refocused from the beginning. They were thinking, no, well, we know where it comes from, but then we couldn't find it. It appeared to be different. And then once they knew they were different and they were doing it very well and things went down, then all of again they had to, make another change yet again. And those changes are not very easy. Now, the estimated of new cases of HIV infection from the Asian epidemic model, you can see in 95, heterosexuals make up 81%. In 1995, in 2015 it's 47, homosexual men in 95 6%, and now it's 43%. So next year, I expect, actually it's in their projections, that homosexual men will make up the majority of new HIV cases reported in Thailand. So they have gone from protection to risk, and now they own the epidemic like everywhere else. And so here below, there is some other crucial information. The estimated prevalence in the country among adult men is 2%, and women is 0.5%, and in MSM it's estimated 7.1%. At least it's estimated by the Asian epidemic. No, it's not estimated as by the Asian epidemic model. It's used as input I make the same mistake now and do the same. It's used as input in the Asian epidemic model, so it's not output. So we should not confuse the two. Otherwise, we get in, we'll be running behind our own tails, and that's going to take a long time. So it goes, that one goes down, and then this one goes up. These are the cumulative numbers, 95 and 2015. Maybe just for you to remember, because we tend to get numb a little bit about all these numbers. But in Thailand in 2015, there's 1,200,000 people with HIV infection cumulatively since the start of the epidemic. That is a big number. And even though things have changed, it's difficult to see what the route of transmission was. Anyway, it's a very large number. It's actually, most of them were already infected in 95, so I think it's gone down for the heterosexual population, and I think it's probably pretty much under control like everywhere in the region and in the world, except like Julio already said, but just while I was talking about this, it's for the MSM population. Now, the impact of epidemic change, I already alluded to that, but there are many, many consequences if your epidemic kind of changes under your eyes. You're trying to control it, and once you think you have it, it kind of slips out of your hand, and you have to start again. Now, for the heterosexual epidemic, I think the government was in a good shape to address that. They had their STD clinics, they had their contacts with the venues for sex workers, and this and that and everything. But for homosexual men or MSM, the government didn't have a list of venues, or didn't have a, couldn't categorize them, or wasn't calling them in every 6 months for their health check, etc. So they basically didn't know very well how to go about it. And that's one of the problems, I think. It takes time. So last week a paper came out in the Lancet HIV, Temporal Trends in HIV Incident and Risk Behaviors among men of sex in Bangkok, Thailand, 2006 to 2013. I see a lot of my former colleagues here in the audience who actually collected these data. I actually did very little for it, but they did actually the most, as usual, but then I take all the credit. But this came out just last week. I just want to walk you through it, what the situation actually is in that period of 2006 to 2013. It's 7 years. There were 2 cohorts in the Ceylon Community Clinic, which I started with CDC support in, I think, well, I don't know when I started to think about it, but before I started, it was 2006 for VCT and 2005 for the cohort, if I remember well. Anyway, these are the infection data. HTC, HIV testing and counseling, number newly infected 235%, incidence density 5.5. There was a cohort study also with fewer men, but higher number of infections because people were selected on the basis of their risk, so there was entry criteria and so on. And the percentage infected, 17%, but the incidence density about the same. So about 5% of these men becomes infected every year. And if you look at the age, which I said here, they had double the odds of acquiring HIV infection than older men. So, and that may not be so strange because older men, of course, they have been young. So when you're old and you have been young, so you had your risk at that time, and so many of them are already infected. So it's also kind of it's also logical that happens. But still, because we associate young with vulnerability and a long, healthy life and those kind of things, so it's disturbing for us. Now, these are the incidence data. You can see over time it's going up and down. It's not really, there's an up and down pattern, but if you look at the calendar time, it's kind of hard to predict. Probably have to build up epidemic momentum, so then you get a number of acute infections and then you get another burst. And it's a little bit same also, go up, down, and circulates a little bit around the curve in the cohort study. So these are really seasonal, and some of the work actually done in the United Kingdom has actually shown that the epidemic over there, at least according to that model that these people used and phylogenetic work, that the epidemic in the UK is actually a consecutive sets of acute HIV infection-related outbursts, and they can see that from the phylogenetics, and probably be the same here, but we don't have that. We don't have that information. Now, what's underlying there? The main driving factor is increases. Well, I very strongly believe that the main driving factor is the use of stimulant drugs in combination with erectile dysfunction drugs, because that is a very interesting combination, I think, because you not only have the pleasure, which you normally have to pay for with problems having an erection, but then the erectile dysfunction drug, they compensate that, so you can have both. So you have the feeling and you're able to have sex and for a long time. And it happens in a party environment with over a long period of time, maybe 2, 3, or 4 days. People come and go, and it's in a private setting, so it's difficult to control. and it's illegal in this country, so it's very difficult to get at, and actually nobody really knows how to get at that core group of transmitters. On the other hand, anal intercourse goes down, and always condom use goes up. So you see, intercourse goes down, condom use goes up, but then I think it all started to happen after the so-called war on drugs and social order campaign that we had in this country, in which there was a major shift, I think, from tablets into white powder drugs, ice and crystallized methamphetamine and so on, which I think are easier to transport than a bag with 2 million yaba pills. That's kind of asking for trouble. But so I think that changed. I don't know why it changed, but it changed after that war was over and the social order campaign, and the social order was back, and then we had a methamphetamine epidemic and an HIV epidemic hand in hand. Now, I'm not sure. Am I running over time? Yes? How far am I over time? I'm finished? Okay, then I'll do this, finish this very quickly. I just want to point out, we did a meta-analysis in which we, from published studies, in which we estimated the percentage of MSM of the male population, the percentage of MSM in that population, 6%. For sex in the past year, and 9% for ever having sex. And those estimates are about double the estimates that are currently used in the modeling. So I think that needs to be revised. We also did the same meta-analysis with more than 100 studies, and we found the pooled estimate of prevalence is 13%, and the prevalence used at the moment is 7%. So I think both the population are, as well as the prevalence. So the population is larger and the prevalence is higher. So I think the problem is much bigger. In the old days, I used to say, well, why do we need to know the size? I'm not into size, because we don't need to know the size for prevention. You know what is the risk behavior, but now you have to roll out antiretroviral drugs, so you need to know how many people you have to serve and how many may come in. How many pills you have to order, and how many physicians, how many laboratories, etc. So now it's actually very important. But at that time I was, I think, naive. Now all kinds of stuff happening there, well, it doesn't really matter because there were dummy data anyway. The point that I want to make here is this is a sort of cascade. I think Julio showed the whole set of cascades, which is, well, I think Julio is one of the persons, oh, there he is. He's, I think, one of the persons that we have to thank very much because he is, I think, not together with Mike Cohen and a couple of other people, I think they've been pushing this agenda for treatment, for prevention, very, very hard. And I think we owe these people a lot because it's the only way at the moment that we can have some impact on the epidemic. Although, then again, I think the impact, the biology is okay, as you just said, but the impact may be limited in MSM because the force of infection is so high and is much higher that the counter pressure of these drugs can give. But what I want to make the point here is this is the treatment cascade, but we need another cascade, and this is the prevention cascade. So if people are positive, they go in Julio's cascade, they disappear to the right. If here's the door, but then if they are HIV negative, they come in my cascade, and if you're in my cascade, then the idea is to see you back, every so many months, and to keep you HIV negative, so that you don't end up in Julio's cascade, because that's not a very good cascade to be. Now, for the biomedical prevention, I quickly, these are, you can see. Asia is empty. If we want to bring PrEP to the country or this region, we need to do more demonstration projects. I think I'll go over this one. And then Alice asked the Queen why this is, and the Red Queen remarks, now here, you see, Alice, it takes all the running you can do to keep in the same place. And Joep 2 years ago wrote a paper or a commentary in the Journal of Clinical Infectious Diseases, and he called it "Under the Spell of the Rat Queen." And I used to tease him with it when I saw him and say, "Oh, you have that Rat Queen again." But he made the point. We're running in one place, we run, but we make no progress. We're not going anywhere because the epidemic is, at least in MSM, is outpacing us. The epidemic runs faster. And that's the Rat Queen. And these are conclusions. Well, you don't mind about if I skip these. One thing, a point I want to make, if we are going to roll out biomedical prevention, we have to adjust, the governments have to adjust, have to look at the drug use laws and policies. Because these two don't go together. You can be effective in HIV prevention if you're still with these antique, archaic, drug laws that you can't even, talk to people about how to use drugs or why they're using drugs or check their drugs for whether they're good or bad, and all those kind of things. All the things that they do in Vancouver. And then, in conclusion, I would just like to echo Joep, what he said in 2013. In conclusion, we need to run twice as fast as we are currently doing, know our classics, and the classics is because this story comes from Alice in Wonderland, and that's one of Joep's classics. Alice in Wonderland is a fairy tale. You may know that, maybe it's not so well known, but we know it all. We need to act upon the classics and upon new opportunities and keep our eyes on the target at all times. Now, there's also a biological component to this Rat Queen hypothesis that it's evolutionary. That the epidemic is outcompeting us. And I was just, this morning I looked at my dog, and he's running after cats. And I was thinking, why are the cats always running faster than my dog? And you know why that is? Because the slower cats have already been eaten, and we are the slower ones. So thank you very much.
Thanks, Fritz. Your inability to keep to time is compensated by your unique insights into the HIV epidemic in this region. Thank you. Our next speaker is Professor Peter Rice. He's from the Academic Medical Centre in the Amsterdam Institute of Global Health at the University of Amsterdam in the Netherlands. He's an expert in metabolic complications and other aspects of comorbidities of antiretroviral therapy, and I can't think of anyone better to speak to you about the topic of HIV and ageing, what clinicians should not miss. A very important aspect as our patients on treatment are getting obviously older. Peter, thank you very much.
Thank you very much, David. These are my disclosures. And since we're talking about aging, I thought I'd start with showing you a few data. These are data from the Netherlands where we, let's go back, where we have the opportunity to actually follow for many years everybody in care with HIV. Seems to be shifting automatically. I don't know, could you switch that off? I think the slides are advancing automatically. Anyway, as they fix it, what the slide is showing you is that is the changing age characteristics of the cohort we have in the Netherlands, and with time, at the moment, the latest data of late last year showed that 13% of people with HIV were already over 60, and it's coming? We'll wait a second. let's see. Okay, so as you see, 13% last year was over 60, 39% was over 50. I think we still have the problem. And what the next chart shows is modeling exercise that Michaela Smith, who is a PhD student with Tim Hallett at Imperial College in London, did using these data from the Netherlands, projecting what the situation would look like in 2040. And as you can see, the mean age would increase from 41 years in 2010 to around 60 years in 2040, and by that time, 80% of patients would be over 50. So of course, this shift is due to actually what we have accomplished, all of us with antiretroviral therapy, in making sure that people can actually manage their HIV disease and stay alive. So it is a good thing. But as Julio, I think, said in one of his remarks, we need to make sure that our patients age graciously, which I think is a challenge for all of us. Unfortunately, as people age, they also have a higher risk of developing disease, and age in that circumstance is the largest risk factor, which unfortunately is something we cannot do something about. This slide really is a visual illustration of the sorts of diseases that we're talking about. And to all of you in the audience who are clinicians, this is, of course, very well known, and the prominent ones, and also in the context of HIV, I think one of the most prominent ones is cardiovascular disease and non-AIDS cancer risk, but all the other organ dysfunctions are amongst them as well. Now, if you try to look at what the drivers may be of these diseases in the context of HIV, then obviously host factors stand out prominently. And apart from age, host factors superimposed on age, which are clearly standing out, are lifestyle-related factors that we can do something about or try to do something about, whereas, for instance, genetic factors is something we cannot change. In addition, ART and ART toxicities, which, as I'll show you later, have declined, still, to some extent, may be influencing what we see clinically in the clinic in terms of their toxicities or ongoing long-term toxicities. And then, with respect to HIV, the current thinking out there is that HIV, despite treatment, may be associated with persistent immune dysregulation and inflammation, which also may be contributing to driving the phenotype, the clinical phenotype of comorbidity manifestations. And what we've seen is that in a number of studies, many of these diseases that I showed you in the previous slide may be more common in people with HIV if you compare it with people without HIV and after you adjust for age and lifestyle-related factors. Now, given the fact that when this concept came out, we weren't completely convinced that this was necessarily true, and we also realized that we didn't really have numbers to put to this hypothesis, we decided to embark on a study in Amsterdam, a cohort study called the HIV cohort study, where we look at comorbidities, their risk factors, and aging in people with HIV. And we very much modeled the cohort study on the old Amsterdam cohort study that started in the mid-80s at the start of the HIV epidemic. It started enrolling participants in October 2010. And we look at HIV-1 infected participants that we recruit in our own HIV outpatient clinic at the AMC in Amsterdam, and uninfected participants are enrolled by the Amsterdam Public Health Service, which also was very much involved in the old cohort study, in their sexual health clinic, and also amongst participants in the ongoing older cohort study. And the reason why we decided to do the study that way is that we were hoping that the background of these individuals who already were HIV infected and those that were being seen in the sexually transmitted disease clinic, particularly with respect to behavioral factors, might be similar. But of course, we were taking a risk. Now, as we speak now, we have, and we've stopped enrolling for the moment, we've enrolled over 500 individuals in each of the groups. Their median age is around 52. Most of them are male. The majority is MSM, which is reflective of the epidemic, and also people coming to the sexual health clinic. In those with HIV, they've been infected with HIV for a prolonged period of time. They had a reasonably low nadir CD4 count at the time of diagnosis, but as you can see from the time that they have spent with a CD4 below 200, they actually were put on treatment fairly soon because that time was fairly short. And currently they have a much improved CD4 count. The large majority of the cohort that we're talking about are people with suppressed infection on ART, and they've been on ART for a prolonged period of time. Now, if you look at comorbidity risk factors, they're fairly similar, but the people with HIV, as has been seen in more studies, have a tendency to smoke more. There's a slightly higher tendency for severe alcohol use in those without HIV. And if you look at recreational drug use, it's very similar except for ecstasy, which is more commonly used amongst those without HIV. BMI, those with HIV, not surprisingly, have a slightly statistically significantly lower BMI, and their blood pressures are significantly higher, although the difference is in absolute terms is not that great. Now, when we first analyzed the baseline prevalence, and this is by self-reporting of comorbidity events, which were subsequently validated by chart review and also by requesting records from those without HIV from their general practitioners, we did find that the people with more than one or more comorbidities were significantly higher amongst those with HIV. And this is depicted in relation to the age category more visually on this slide, where those in green represent the people without any comorbidities. The ones in yellow have 1, the ones in brown have 2, and the ones in red have 3 or more comorbidities. And one thing you might say from these data is that if you look at these color distributions, it seems that those who are HIV infected with a similar distribution of comorbidity number than compared to those without HIV, that they are approximately 5 years younger. But I would caution to say that this in no way proves or refutes the hypotheses of potentially premature aging amongst those with HIV. What I think is clinically the most concerning finding to me is that if you look at multimorbidity, the proportion of individuals with 3 or more comorbidities, especially in the higher age groups, those above 60, the amount of red representing those groups is clearly higher in those with HIV. And of course, a limitation of this is that the absolute number of participants that we are looking at in these higher age categories at the moment is still fairly limited. So I don't think we should draw definitive conclusions from this. But if this is the pattern that will evolve as we go along, that certainly for clinicians is a major concern. And if I look at my own clinic experience, this is certainly the experience that I have in my clinic, which my clinic population is actually a group of people with long-standing HIV that I've been following for many of them for 10 or 20 years. So they're relatively older, and the main concern and the main work that I do when I do clinic is indeed managing multiple comorbidities at the same time. So if we look in the cohort at the specific distribution of specific types of comorbidities, I think the data so far suggest and show that cardiovascular disease across the board, including peripheral arterial cardiovascular disease, is more common in those with HIV, and chronic kidney dysfunction, chronic kidney disease is also more prevalent. The other ones have not reached statistical significance yet, but numerically, the pattern does show that every disease that we look at is more common in those with HIV. And here I'll show you a few slides zooming in on a number of the assessments that we do. We do DEXA scanning on all participants, and we do exactly the same assessments in those with HIV and without HIV. This is looking at the result of DEXA and looking at the distribution of osteopenia and osteoporosis at different places, the lumbar spine, the femoral neck, and the total hip. And the picture that emerges is indeed, again, that osteoporosis and osteopenia is more common in all 3 locations. We also looked at hypertension, And again, you find more hypertension, and I think this is really one of the most common issues, more hypertension in those amongst HIV, both if you look at measured hypertension, but also counting those that have been diagnosed with hypertension in the past and are currently, if you measure them, have normal blood pressure but are on antihypertensives. Frailty is another issue that we look at, and here you see a slide where we look at the distribution of frailty broken down by age categories, and again, the picture that emerges is that there is more frailty and pre-frailty at any age in HIV-positive participants. And these are the 5 characteristics that you actually determine in order to come up with a frailty score. And again, when you look at each of these different characteristics, each of them is more common in those with HIV. Now, I've tried to make a composite slide. We've done these analyses, of course, for all of the individual comorbidities that I've shown you before, but I decided to make the effort and try to put all of the data together to see what sort of picture emerges, because I think the key question, of course, then becomes, if all of these issues are more common in those with HIV, then what are actually the underlying risk factors and what are the associations? So I think one thing to stress is that in all of these, and fortunately, because if it wouldn't come out, then I would be concerned about our data collection, but it's important to point out that recognized traditional risk factors for each of these diseases clearly are associated with them. And I'm stressing that because clinically, of course, that's the primary thing that we should try to be addressing. Now, with respect to HIV, and that was one of the prime reasons for doing the study, HIV is associated indeed with each of these diseases, being HIV positive. But if you zoom in a little bit more, then you see that if you look at the number of these comorbidities, so remember the first sort of traffic light slide that I showed you about the number of comorbidities that people had, then I think one very important thing that comes out is that the time spent with a low CD4 count clearly comes out at the risk factor. And I don't show this for the other diseases, so hypertension, cardiovascular disease, low BMD, and frailty, but also in those analyses, not necessarily statistically significantly, but the trend is always there for time spent at low CD4 count or CD4 nadir to be in some way associated. Which of course speaks to the need for early diagnosis of HIV and preferably early treatment, which might make a lot of these things go away. With respect to hypertension, it was clear that the association with HIV was reduced if we put waist circumference into the model. So abdominal obesity is clearly a risk factor. For low BMD, the association with HIV clearly was reduced if we put body weight into the equation, and it's known that low body weight is a risk factor for low BMD. And for frailty, interestingly, a history of a low BMI or low weight or a current low weight was also associated, which to us suggested that maybe people who have gone through the process of having had their HIV diagnosis late and may have gone through a situation of either clinically overt wasting or some degree of wasting, that having gone through that, even though they are now currently on antiretroviral therapy, may still leave some residual risk for developing frailty later on. Important point to make is that if you looked at the association with the use of ART in general, for none of these situations was there any association between the risk of developing these diseases and the duration people had been on treatment. And if we try to zoom in on specific ART exposure, what came out is that really people who were exposed to high-dose ritonavir, and high dose in this circumstance was defined as 400 milligrams per day or more, which is something that we currently don't use anymore, was a risk factor for some of these entities that I discussed. So coming back to the importance of lifestyle related factors, and I think that is something that I can't stress enough, A recent analysis that was done by the ART cohort collaboration and just, I think, published online this week or last week, shows the importance of smoking and shows that if you look on the right, that well-treated HIV-infected individuals, in fact, may lose more life years through smoking than through HIV, which I think clinically, for those of us, is not really surprising, but it's important that this came out. And that the excess mortality, and that's a concern again, that the excess mortality associated with smoking increases markedly with age. And that addresses again the concern that I voiced earlier on about the multiple comorbidities in people who get older, that it might suggest that increases in smoking-related mortality can be expected to be more prominent as the treated HIV-infected population ages, and therefore I think it also clinically stresses the need for interventions which address smoking cessation. Now, the relationship between age and smoking, in this case on cardiovascular disease measured by carotid IMT, might be changed. And what you see here is that people in the older age brand, here these are people older than 50, who are HIV positive, the effect of smoking on IMT may actually be greater in those with HIV than those without HIV, which of course again is not good news. As far as ART toxicity is concerned, and this has been, I think Julio was the one who said that, ART clearly has become less toxic. What the slide here illustrates are again data from our Dutch HIV cohort, which looks at people who initiate treatment for the first time and reasons for needing to modify treatment in the first 3 years of treatment. And toxicity as a reason, and that's shown by the very light color, this color over here, toxicity has clearly declined as being a reason for switching therapy. But if you look at the distribution of reasons, even in the latest time period, in a relative sense, it still remains one of the most important reasons. Now, of course, some of these ART toxicities that we know about may accentuate the clinical expression of certain comorbidities. For example, cardiovascular disease, the risk may be increased by certain of the protease inhibitors, and I've put a question mark because I think there's still an ongoing debate with respect to abacavir. If you look at bone disease, then clearly tenofovir maybe accentuate bone loss, bone mineral loss. And if you look at renal disease, we of course know about tenofovir, but there also may be a separate risk from certain of the boosted protease inhibitors, notably atazanavir and lopinavir. And with a question mark, I don't think the data is really strong enough yet, possibly also for darunavir. Now, in that sense, of course, it's important to stress that ongoing development of new drugs and ongoing development of drugs which may improve on this profile is very important. And one of the promising ones is tenofovir alafenamide, of which I think more data in large-scale trials with respect to toxicity may be presented at CROI next month. It's a prodrug of tenofovir, and ultimately one of the characteristics is that it reduces the circulating level of plasma tenofovir. And it's actually the concentration of plasma tenofovir which may be responsible for the off-target effects, for instance, on bone and kidney. And because of the lower concentrations of circulating tenofovir, the renal and bone toxicity of tenofovir alafenamide may therefore be less. And this is indeed supported by data from a very early trial. This is a trial in which the combination of tenofovir, emtricitabine, cobicistat, and darunavir was compared with exactly the same combination, except that we're looking in the green line at tenofovir alafenamide instead of tenofovir dipivoxil. And as you can see, the early rise in serum creatinine indeed is less if you put tenofovir alafenamide in the mix. Even more impressive, I think, are the changes in bone mineral density in this trial. and I think this will be confirmed by the larger trials, where you see that we know about the early reduction in bone mineral density with most of the antiretroviral therapy regimens in anyone who starts antiretroviral therapy for the first time. But here you see that this reduction is clearly less with tenofovir alafenamide than it is with the older version of tenofovir. Now, with respect to serum creatinine changes, we need to realize that a number of the drugs that we use, including some of the neuro drugs like dolutegravir, rilpivirine, and also the booster cobicistat, may actually impact on tubular creatinine excretion and inhibit that and thereby increase serum creatinine. So when looking at the data of tenofovir alafenamide, especially in trials which combine it with cobicistat, that's something you need to keep into the back of your mind. And this is illustrated, this effect of the, in this case, of the cobicistat is shown in these trials as well. And this is the same for dolutegravir. Now, one of the questions that people continue to ask is whether HIV and the use of ART, in addition, may in some way interact with biological aging and affect the aging process itself. And in that sense, I've put in a slide which is a recent review paper in Cell, which goes into what the hallmarks are of biological aging and how they relate to another. So there's a number of processes which, if they're initiated, triggers DNA damage and progressively, and the consequences thereof progressively accumulate over time. Then there are also a number of responses which in the first instance are sort of compensatory responses which are beneficial, but over time they also become progressively detrimental. And then finally, all of these things eventually lead to the damage and the phenotypic expression of aging and the tissue injury and the clinical comorbidities that we see. Interestingly, if you look at each of these individual biological processes, many of them have been suggested or even demonstrated in vitro studies, mainly using blood cells, could be affected by either HIV or ART or both. And these are a number of examples, and these are particular papers actually from our Australian colleagues as they're sitting here in the audience. I put this slide together for the Melbourne conference, and it's work, very old work that David was involved with a group in New York, I think, and Sharon's team, who have looked at a number of these processes. And as I said before, many of these studies have been done using blood cells, and we know very little about what may happen if these processes are affected in tissues. So I think it's an interesting concept, and certainly in view of the higher incidence of these age-associated diseases and the plausible mechanisms. However, I think it's important to stress that it remains a hypothesis that either needs to be proven or refuted. It will need reliable markers of biological age to be designed to be applied to longitudinal clinical studies, such as what we're hoping to do in our own cohort studies. And finally, with all the limitations thereof, animal models may also potentially yield more insight and may allow us much better to distinguish between the effects of HIV and treatment. And that's something that we ourselves are trying to address in the HIV cohort study, but also in this EU program that we're running with colleagues mainly in the UK and other European countries, where we're trying to put all of this together. So in summary, I think consistently in most studies, the burden of various comorbidities is increased in HIV. I think traditional risk factors do play a crucial role, and I think this needs to primarily be reflected in our clinical management and care. Independent associations with HIV are observed for some, but not all comorbidities, so I think it's dangerous to generalize. I think overall the picture is emerging that longer time spent at low CD4 counts rather than longer exposure to ART generally contributes to greater comorbidity risk. And again, this stresses the importance of early HIV diagnosis and treatment. I think persistent inflammation and innate immune activation generally, but again, we shouldn't be dogmatic about it, seem to additionally contribute towards risk, and the pathogenic pathways involving effects on the biology of aging need further exploration. And finally, I'd like to acknowledge many of my collaborators, the study participants, our funders, people that I've had the pleasure to work with and discuss these matters with, and finally, my last slide disappeared, but I had a slide actually of a photograph of Joep and Jacqueline because I'd like to dedicate the lecture to them, and we'll see if we can show you that later. I also put in a little drawing that actually a relative of Jacqueline made after Joep and Jacqueline's funeral ceremony to thank people who came to the ceremony, which is a very nice cartoon, particularly of Jacqueline, somewhat less of Joep, but it also shows Joep's dog in the cartoon, and it reads, "It is silent in Amsterdam." And I think the dog, I didn't mention that in my opening remarks, but Joep was unusual in many ways, but I think he's also the only person I know who always brought his dog to work. And the dog is called Lizzie, and Lizzie even, which was very touching, Lizzie was also present at their funeral service, didn't make a sound throughout the ceremony, which lasted for an hour and a half, and still comes occasionally to work and visit us. So I thought I'd end on that note. Thank you very much.
Thanks, Peter. I think this session has run over time, the whole of the session, because of its importance. So I think people would like a break. So what I suggest is that we break now, and if you could make sure you get back here by 25 to 11. So we've got a 20-minute break instead of a 30-minute break. So thank you very much.